they may do a C-section. That gestational age. If the mom is term, if they're close to term or term in their pregnancy, they're going to deliver. They're going to expedite delivery, meaning an induction or a repeat section if that's the case. If they're premature, then they may hold off and wait and see what happens. Okay. It's beneficial to keep the baby in a little longer, even though the amniotic sac is ruptured. Then we'll do that as long as there's no signs of distress, no signs of infection.
Do they put more fluid in?
Not usually. It would usually only be like during labor. Sometimes if it's a small little leak in the sac can reseal and fluid can reaccumulate. But if they're premature, then sometimes it's better to let the baby stay inside and continue growing than deliver prematurely. So it depends on gestational age and things like that, and if there's any signs of infection. So it's the risk of early delivery against the risk of infection. Oftentimes, moms will be hospitalized until delivery, just so that we can monitor closely for infection. But sometimes they may be sent home, and if that's the case, then they need to know, what signs and symptoms to monitor for, which I think I have the next slide. The other concern is that, think of our functions of amniotic fluid, right? It maintains even temperature, allows for symmetrical growth, allows the baby to move around freely in there. So if there's no amniotic fluid, then, growth can be impacted. Growth of lungs can be affected, right? Because their lungs grow throughout gestation because they're maintained by amniotic fluid. That's what keeps them expanded in utero. So low or no amniotic fluid can lead to fetal pulmonary and skeletal defects. So if the mom is being sent home after her water has broken, reported temp above 38, nothing, no intercourse, no nothing. Okay, risk for infection. I don't know what you said. I don't want to know what you said. I know. Avoid orgasms, avoid breast stimulation, anything that could get labor going. Right? Anything that can stimulate labor. You don't want to do any of those things if you're being sent home because your amniotic sac is ruptured. Maintain activity restrictions. Monitor for contractions, monitor for fetal movement. If there's any concerns, they should talk to their provider. All right, preterm labor, some risk factors. Some women are at a higher risk for preterm labor. Some people just have preterm delivery without any risk factors. So they're all listed here: underweight, chronic illness, dehydration, any medical condition for the mom, like high blood pressure issues, problems with the placenta. Sometimes they may elect to deliver prematurely if the placenta is not performing at a good capacity, because the baby may be better off being on the outside. More than one baby often results in premature delivery because you run out of room. The uterus runs out of room. There's no room at the end. Preterm labor occurs after 20 weeks and before 37 weeks. So one of the Health People 2030 goals is that 90% of all women receive prenatal care starting the first trimester. The major cause of perinatal morbidity and mortality has major medical and economic impacts. Signs of impending preterm labor. When you go for an scan, which most people do during pregnancy, that's around 20 weeks, about halfway through, and they will do a transvaginal ultrasound, and they'll check the length of the cervix. Remember the neck of the balloon? Mm-hmm. Okay? So if your cervix at 20 weeks is already shortening, you're at increased risk for preterm labor. They may put you on bed rest. They may do a procedure called cerclage to keep the cervix closed. You may just be followed up more closely in the upcoming weeks to make sure you don't have a baby prematurely. But that's one of the predictors for preterm labor, is that shortened cervix. The other item that we can look at is something called an FFN, or a fetal fibronectin test. Right? Fibronectin is a protein produced by the baby, or produced by fetal membranes, and it can leak into vaginal secretions if there's any uterine activity. Okay, so if there's FFN, if we have a positive FFN, then we've had some uterine activity, and it could indicate that delivery will happen within the next 2 weeks or so. So that's another thing to look at. For contractions, feeling like the baby is like kind of balling up or curling up. Menstrual leg cramps, constant low backache, pelvic pressure, may have some change in vaginal discharge, cramping. Sometimes I'll just say they don't feel great. And, if you're having, realize that these are signs of preterm labor. You just be like, oh, my back's been sore. And not realize that that could be a sign of preterm labor. Treatment depends on the level of maturity. And I'm not going to go through this slide. This is actually probably delete this slide. It just talks about an algorithm that was developed to give steroids to the mom at an appropriate time. Okay. Everybody that had any sign of preterm labor, they were just popping them with steroids, beta-methadone injections. The real benefit is when they're given within a few days of delivery. So they designed this toolkit to kind of determine, probability of prematurely or not steroids should be sort of tocolytics contractions. Okay, so if somebody preterm labor, we tocolytics to try and stop those contractions from occurring. Long enough until the lungs are mature, even just a couple of days where we can get some steroids to mom to help with lung maturity. That is better than not having steroids at all. Magnesium. Where else do we give magnesium sulfate to preterm labor? Because magnesium is for the head, right? A neuroprotective medication. So for moms that have preeclampsia, we're giving it to hopefully prevent the seizure from happening. The baby develops cerebral palsy. Okay, so it has a lot of nice side effects like lowering blood pressure or slowing contractions down, but the main reason we're giving it in this scenario is to protect the baby, and we give it in preeclampsia to protect the mom's brain, or prevent the seizure. Right, so think as a head med. That way. Medicine head. Okay. Other tocolytics that can be given. There's terbutaline, indomethacin, and nifedipine, all contractions pretty quickly. The med that they choose will depend on some other things like if there's any pre-existing cardiac or blood pressure issues, then we may want to stay away from terbutaline. Indomethacin can cause dig back to chapter 3, our ductus arteriosus in the baby that's supposed to be open in utero. Indomethacin can cause that to close prematurely, which we don't want to happen, so we have to use that with caution. Nifedipine is the other one. Contraindications to giving somebody tocolytics. We do not need to stop labor if there's no benefit in delaying birth. So if somebody has preeclampsia and they're 35 weeks pregnant, then let's just let it happen. They're not that premature. It's going to be better at that point to let the baby deliver. placenta previa, an abruption. Gestational age over 37 weeks, there's no point in delaying. Chorioamnionitis is an infection in this. Okay. Better get the baby out so the baby doesn't get infected. Or fetal demise. Here's our little, because these are our tocolytic meds. It's not my time. Okay, it's not my time to be born, so these are the medicines so that I am not born. Independent, amphetamine, or terbutane. Surfactant in the baby, which is with love maturity. And steroids are betamethasone, 2 IM injections 24 hours apart. So even if we can hold off for a few days, get those 2 steroid shots in, it can that baby more towards the 24-week mark instead of 34. That's it. Late term is from 41 weeks to 41 weeks and 6 days, and post term is 42 weeks and beyond. Usually by the time you get to 42 weeks, they're checking in. You get evicted. Evicted. Post-mature accurately describes the infant whose characteristics are consistent with spending too much time in utero. They have a look. They have a look. The concern, once you go past your due date, is that that placenta is not working as well. Okay, so when the baby is not getting enough oxygen and nutrients from the placenta, you know, they can have issues such as asphyxia, related to asphyxia, if they're getting deprived of some oxygen from the placenta. They're not getting the nutrition they need, so they start to kind of use their own calories, they burn their own calories, which results in weight loss. Sometimes they look, you know how elderly people don't have any muscle mass? They don't have a lot of fat. It's just like, you know, very loose skin. Post-term babies look the same way. They're very long and thin and they look like they lost weight. Their skin is kind of loose. They've lost that layer of subcutaneous fat or brown fat because their placenta is not giving what they need. So they look like they lost weight. If the placenta is not working, they are not going to tolerate labor. They are going to be stressed out. They can also have that stressful environment can cause them to release meconium into the amniotic fluid, which has its own set of risk factors, right? If they accidentally inhale that. Low blood sugar. And on the flip side, if the placenta continues to work, then they're just going to be big. Big, healthy babies. There are problems with having a giant baby instead. So the provider will determine whether or not the pregnancy is truly past the due date or maybe the dates were incorrect. This is why that early ultrasound is important, because at 8 weeks-ish, they all look like little bears. They all measure the same at 8 weeks. So the early ultrasound to determine that yes, indeed, this pregnancy is 8 weeks along, you know, will help down the road to determine, are they really past their due date? Do we have questionable dates? You know, and because we don't want to intervene if somebody's not truly at their due date. But size can vary at that point, which is why some babies are 9 pounds and some babies are 5 or 6 pounds. If you get the due date and beyond, they're going to do some more mirroring to make sure the baby's okay. Like our non-stress test, biophysical profile, they'll measure amniotic fluid, make sure that you have enough amniotic fluid in there, and they'll ask mom to check kit counts, monitor kit counts. This is kind of what they look like. They lose, you know, vernix and lanugo. Vernix is the cheesy substance that's all on babies when they're born, right? Usually they have it like in the creases, in their groin, behind their knees. That protects their skin from amniotic fluid. It starts to go away as they get to their due date. So if they go beyond, they lose that vernix, their skin gets very kind of dried out and peely. This baby also appears to have had meconium, because see how it's like green? Okay, so that's meconium stained. and these very long fingernails that are also meconium stained. His hands are peeling. This looks like a chest tube dressing, which also goes along with having a meconium aspiration. So, you know, that's what they look like. And they're very long and thin and have no subcutaneous fat. So our last few slides, we'll go over emergencies during childbirth. We'll talk about a prolapse cord, placenta accreta, and uterine rupture. Prolapse cords come up a couple times so far. That the cord can prolapse when the amniotic sac ruptures, and that cord kind of slips through the opening of the cervix or slips down somewhere where it can become compressed. So you can have a complete cord prolapse where the cord is visible at the vaginal opening. You can have a palpated prolapse where you may not be able to see it, but you can feel it, because you'll feel it palpates like the baby. It goes with the baby's heart rate. As a matter of fact, if we're, when the baby's born, if you don't have access to a stethoscope, which you should right away, or if it's an emergency situation, you can pinch right at the base of the umbilical cord, and you can get a heart rate. It's like an extra pulse for a short period of time after the baby's born. And then of course, you can't see it or feel it, but you kind of presume that it's happening based on the changes in the baby. You're not necessarily going to see or feel it, but it's like that cord slipped down beside the being put up against the baby. Lots of variable decelerations, right? Our variable decelerations go with cord compression. Palpated, you may not feel it, and these two you'll be able to see. Ruptures more likely if the baby doesn't completely fill the space, right? Or if the baby's facing the wrong way. There's not a good seal like there usually is with the baby's head up against the cervix. It leaves room for that cord to slip around. So if this happens, the physician may push the baby upward. They're going to give mom oxygen. They're going to give her a tocolytic to stop the contractions altogether, and they're going to run her right into the operating room to take that baby out. We have to get the baby off of, relieve the pressure on the cord. Okay, so the provider may use their hand and do a vaginal exam and kind of push the baby's head off the cord while they're running into the operating room. Mom can change positions and kind of do like knee to chest, lay on her side, something that uses gravity to shift that baby down a little bit off of the umbilical cord. All right, next up is placenta accreta, which we saw in the C-section video. With placenta accreta, we have abnormal attachment of the placenta to the wall of the uterus. This is common with previous C-sections, fibroids, increased maternal age, or endometrial defects. That area where an incision was made is a weaker area, and it can allow that placental tissue, because again, it's not malignant, but it acts like it in that it rapidly grows, and it can enable that placental tissue to kind of grow into the wall of the uterus. So symptoms include profuse bleeding at attempts to deliver the placenta after the baby's out. Okay, if they can't control the bleeding, then they may need to do a hysterectomy. If you have an accreta and you know you don't want to have your children, bless you, you can elect to have a hysterectomy rather than try and deliver the placenta. Okay. There's different variations of an accreta. Okay, we have our normal attachment here, where we're attached on the endometrial layer, and with an accreta, we're growing beyond the endometrium. All the way up to a percreta, where placental tissue can actually grow completely through the uterus and attach to the bladder and other organs nearby. In that case, you would need to have a hysterectomy. Okay. With the Creta, they can, try and get all the placental tissue out without doing a hysterectomy, possibly. But the more invasive it is, the higher the chance of a hysterectomy. And they oftentimes, they'll even do these sometimes in the main operating room, so that they have more space, and they will have trauma surgeons scrub in as well, because that's what trauma surgeons do. They manage, massive blood loss, because it is all right, uterine rupture is a tear in the uterine wall. This can happen if the muscle can't withstand the pressure inside the organ. So think of it like, well, I guess like a water balloon, right? If you fill up a water balloon, you fill it, and then you squeeze it like it's too much pressure and it pops. So the same thing can kind of happen with the uterus. It's not that common, and more likely to occur if you've had a previous surgery, because that area is weaker, right? You can have a complete rupture where you have a hole through the uterine wall, an incomplete rupture where the uterus, it can tear to a nearby structure such as a ligament, or a complete dehiscence, which is the separation of an old uterine scar. More likely to occur for somebody who's had previous surgery on their uterus. So this is why you need to have a surgical team present for anybody who's attempting to have a vaginal delivery after a C-section. Characteristics of a rupture: shock caused by bleeding into the abdomen, abdominal pain, pain in the chest, contractions stop because it's no longer a whole muscle, right? There's a break in the tissue, so there's no contractions. Abnormal or absent fetal heart tones, so get a heart rate on the baby, and palpation of the baby outside of the uterus if they've pushed through that tear as well. I've seen that once where they found the baby floating in the abdomen.
Hello.
The mom had a rupture and the baby made its way through the rupture, and the uterus was like, great, this baby's out, and contracted, and the baby was in the abdomen just floating around.
Live. He was exploring.
He was exploring.
I wonder how that felt.
Huh?
I wonder how that felt. I don't know that, like, that's crazy.
That baby did
These
not
kicks
make
are real strong.
it. Well, no, the baby did not survive.
Oh, I was thinking that. I was wondering. Did.
Last up is amniotic fluid embolism, which I feel has gotten more attention lately because there was like a nurse influencer that just had one, I think, an amniotic fluid embolism. And she didn't make it. Nurse Haley, something like that. She did like study guides for nursing students. Yeah, she did.
Oh, yeah, I thought everybody prayed for her. But
Yeah.
she died.
It wasn't Nurse Sarah, was it?
Sarah? No, I don't think so. Nurse Haley. I think it's Haley.
Sarah.
You have your Instagram.
Now I'm gonna look at
Was it Haley?
Nurse Sarah.
Yeah,
She's blonde, right?
I think so.
Yeah.
The baby survived. So fluid embolism.
33.
Yeah, she was young, 33. With a fluid embolism, this occurs when amniotic fluid, along with anything that's in the amniotic fluid, finds its way into mom's bloodstream. Okay, there could be a very small tear in her skin and her tissues, and like complete vascular collapse for the mom as soon as it happens. So abrupt onset of hypotension, respiratory distress, clotting abnormalities. It's hard to recover the mom from this. You have to recognize it immediately, and even then, even if you're in the hospital, it's hard to recover. So we need prompt identification to save mom and infant. And again, pretty rare. I've only ever seen one in 20, 22, 23 years. So, seen it once. Treatment, mechanical ventilation, so breathing tube, they go on ICU level care. And that's all for chapter 8. Any questions? No? Hmm? Oh, Haley, oh, okay. Yes. Oh, cool, is that what you said? Yeah. And she did like stuff or something for her to see. Remember things. All right. Well, you guys are gonna have a longer dinner break, 'cause I'm certainly not gonna start another chapter for 2021.
Cool.
So next week, we have our test, right? Where are we here? Next Tuesday is the 5 o'clock. Yep, so we'll do the test on chapters 5, 6, and 7, and then we'll start chapter 9. Chapter 9 will take a couple days. Okay.